Okay, Chair, we are live on YouTube and it is 9 a.m. You may call the meeting to order.
All right, we'll call the meeting to order for the Patient Protection Commission. Could we call for the roll call?
Absolutely, Chair. Commissioner McAllister.
Here.
Thank you. Chair Khan.
Present.
Thank you. Commissioner Roe Dugan.
Present.
Thank you. Commissioner Grady.
Present.
Thank you. Commissioner Van Houweling.
Oh, good morning.
Good morning. There you are. Thanks. Commissioner Bond.
Here.
Great,
Present.
thank you. Commissioner Tyler Garner.
Present.
Thank you. Commissioner Winkler.
Good morning, present.
Good morning. Thank you. Vice Chair Rubelit.
Good morning, present.
Good morning. Thank you. Commissioner Ralston.
Good morning. I'm here.
Good morning. Thank you. Commissioner Serbo.
Present.
Thank you. And Commissioner Khan. Okay. Mark is absent. All right. And then just quickly going on to our ex officio members, Director Richard Whitley.
Here.
Great. Thank you. Insurance Commissioner Barbara Richardson.
Morning.
Good morning. Thank you. Executive Director Ryan High.
Present.
Great. Thank you. And Executive Officer Laura Rich.
I'm here.
Great. Thank you so much. Chair, you do have quorum.
Thank you. So the next item for action on the agenda is the approval of October 19 minutes. Do I have a motion to approve the minutes?
Chair Khan, I'd like to make a motion to approve the October 19th meeting minutes of the PPC.
Thank you, Commissioner Van Houweling. So do I have a second?
Commissioner Winkler, I second.
Thank you. Any opposed? Hearing none, the minutes are approved. Public comment, Melinda, do we have anybody on public comment?
Sure. Let me go over, navigate here. If you would like to give public comment and you are on the Zoom platform, please use the raise hand feature. Additionally, if you are calling in via telephone, please press *9 to raise your hand. And I do see we have public comment. I'm going to go first to Helen Foley.
All right. Please keep in mind, we have 3 minutes for presentation.
Good morning. On behalf of the Nevada Association of Health Plans, we want to address some items before the PPC today. The concepts and materials are voluminous, but we want to highlight some of our preliminary concerns. Slide 7 on guiding principles speaks about the PPC's work being informed by a diverse group of stakeholders and that the PPC will educate itself and actively collaborate with state agencies and organizations. We have engaged with the PPC throughout its tenure. However, there is no representation by health plans on the PPC. Today, we ask, can we engage more meaningfully with this commission? We find that at almost every meeting, questions arise regarding insurance, and there was no one to weigh in to provide needed information. An insurance executive was asked to be part of your stakeholder advisory group, but the expanded stakeholder group was rejected by the PPC. Regarding the cost growth mitigation strategies, we would like to reiterate our concerns on impeding access to care with provider price caps and price growth caps. What mechanisms does the PPC envision having as guardrails in case this has unintended consequences? NVAHP is very concerned about including large groups in rate review. Large groups are rated based on their experience. However, the current proposal indicates that a community type rating with a variable high and low amount is being proposed to you today. Groups that would have gotten a lower premium because of their experience would now have to get a higher premium to offset a group that has higher medical costs. For example, a group that has 51 employees could end up subsidizing a group that has 2,000 employees. Since large groups have more flexibility in designing their benefits than individual and small groups, this could also impact the plan design for large groups. We often have large groups wanting to provide more benefits, but there may be hesitancy based on the need to have rates approved. Better performing groups would have more incentive to self-insure and pull out of the fully insured market, which means that the cost of large groups would then go up. We also caution you to be very careful about inflation. The PPC cannot view these targets in a vacuum. Inflation will influence costs from the providers in the hospital setting and in premiums. The PPC is focused on reducing premiums by reducing administrative and provider costs. Now, everyone knows that the rising cost of prescription drugs is also one of the main drivers of premiums. We encourage the PPC to explore ways to reduce the cost of prescription drugs to have any meaningful impact on premiums. NVAHP looks forward to continued conversations regarding these important issues, and we thank you for your time.
Thank you very much. Appreciate your input. Just a quick comment. FYI only that the public comment section is always open to anyone who would like to present anything. So we welcome your input. Thank you.
Okay.
Anybody
Chair?
else? Melinda?
Yes, we'll go next to Patrick Kelly.
Good morning. My name is Patrick Kelly, and I'm the CEO of the Nevada Hospital Association. Today, I'll address healthcare expenditures, and then I'll address the fundamental issue that affects health insurance premiums in Nevada, cost shifting. The Kaiser Family Foundation reports that Nevada's healthcare expenditures per capita are among the lowest in the country. In fact, Nevada has the third lowest healthcare expenditures per capita in the United States, the third lowest. All the other states participating in the Peterson-Milbank Healthcare Benchmark Project are much higher. Nevada's healthcare expenditures per capita are $8,348. Massachusetts is $13,319. That's 55% more than Nevada. Delaware, Connecticut, New Jersey, and Rhode Island are all thousands of dollars higher than Nevada. An important question to ask and consider is, do states with higher healthcare expenditures per capita have better patient access? We know Nevada has the third lowest healthcare expenditures per capita in the nation, and we have poor access. Now, some may say, okay, we have one of the lowest healthcare expenditures per capita, but our insurance rates continue to increase. Let me address that. One of the reasons is cost shifting. Cost shifting occurs when some groups don't pay the full cost of care received and other groups make up the difference. In Nevada, cost shifting primarily occurs from government payers to non-government payers. This is important because Nevada hospitals treat a disproportionate number of Medicare and Medicaid patients. Medicaid and Medicare beneficiaries represent 37% of Nevada's insurance market, but they comprise 70% of the patients treated in our hospitals. This distinction is crucial because Medicaid and Medicare payments don't cover the cost of healthcare provided to their beneficiaries. I outlined the specific numbers and written comments that accompany today's meeting materials. Another 5% of hospital patients are uninsured. Typically, they're unable to pay the full cost of care. So here's where things stand. Approximately 75% of the care provided in Nevada's hospitals is subsidized by non-governmental payers. That's substantial. The remaining 25% of patients are charged their cost of care plus the shortfall. If we want to improve access to care and lower the increases to the 25% of commercially insured patients, cost shifting must be addressed. Government payers must cover at least the cost of care provided to their beneficiaries. Thank you, and I wish you all a very happy Thanksgiving.
Thank you very much. Appreciate it. Anybody else in the public comment, Melinda?
Yes, Chair. And we will now go to Nicole Chauvet.
Go ahead, please.
Hi, can you hear me?
Yes.
Okay, perfect. Thank you. My name is Nicole Chauvet. I just wanted to question why organizations in Nevada are not following sort of what Governor Newsom recently signed into legislation. I don't know if you guys heard about it, but he is making efforts to modernize California's medical malpractice system. And in doing so, they have raised the caps for wrongful death lawsuits in order to compensate for inflation. And also the major concern is that patients do not have rights in this area. A lot of patients cannot get an attorney, cannot obtain an attorney for medical malpractice because the caps are so low. And this is wrong, especially when it comes to wrongful death. If you had a loved one who passed away, such as I have recently, you would understand the struggle that you go through when you feel as if you have no justice. I question how we got here. There is no way the community members of Nevada would vote for their rights to be taken away like this. So what got us here? I understand the concept of keep our doctors in Nevada. However, there has to be balance because the system is currently drastically skewed. What would it take to have a revote to create a system by the people and for the people in this area, not by and for the insurance companies or medical corporations? Thank you.
Thank you very much. Appreciate your input. Anybody else, Melinda?
Anyone else for public comment, please use the raise hand feature or press *9 on your phone if you'd like to give public comment. I am not seeing any chair. However, I do also want to note that the commission did receive written public comment for today's meeting from the Nevada Hospital Association and from Ms. Chauvet, and both were sent to the commissioners on November 4th and are posted to the PPC website.
All right, thank you. If we have no further public comment, the next item on the agenda is the PPC bill draft request update. Melinda, you want to bring us up to date on that?
Absolutely. Thank you, Chair. So the drafted language for the 3 BDRs for the 2023 legislative session has been received and reviewed by the commissioners for any obvious errors or omissions. I did want to note that one obvious error was noted on my part and was completely my mistake for not catching it prior to submitting the BDR form to the Legislative Counsel Bureau. And it is in regard to the electronic health records BDR, in that the words "ensure patients" were somehow omitted from the final version of the intent that was listed on the BDR form to LCB. So I have since been in contact with both our Deputy Attorney General and subsequently the LCB bill drafter, humbly requesting an appropriate revision of the language to match the full intent of the commission. That redo language was received from LCB and sent for review by the commission yesterday, with no additional feedback received from the commissioners. No other obvious errors or omissions were noted, and the 3 BDRs will be pre-filed today in time for the LCB deadline. Upon printing, each pre-filed bill will be made public. And with the PPC BDRs in the hands of the legislature, I will be working with the legislature and transparently sharing the process all along the way. It is my role to ensure the bill language continues to match the intent of the request as you had all decided in August. You will all continue to receive information as I am given, and I will continuously solicit your individual feedback. Future meeting updates on the PPC bill progress will be for discussion purposes only, and this is designed to help manage expectations and the realities of the Nevada legislative process and our responsibilities to follow open meeting laws in our state. Lastly, I'd like to sincerely thank you all for your hard work in developing and submitting the 3 legislative measures for the 2023 session. So now I just wanted to pause and see if there were any questions before we move on to the next agenda item.
Just a comment that I presume everybody did receive, as Melinda mentioned, I did, the language. No specific changes were recommended by any commissioner to my recollection. So in the interest of our efficiency, if something has come up in one's mind since they were sent out, you may speak so now, please.
Dr. Khan,
Yes, Commissioner Bond.
thank you. I got this yesterday. I got the redo from Melinda yesterday. And so I think that it would be great if we had another day to look at it. I think these are important BDRs. I think there's time So could I ask you, Melinda, what is the impact of having a BDR held one more day on LCB's deadline?
So the BDRs all have to be pre-filed today. They
Or what,
cannot be later than today.
what happens if they are?
I don't have any information on that.
Do we have Jack on the line? Do we have the attorneys on the line?
Yes. Hi, this is Suzanne Slita with the AG's office. And I honestly don't know the answer to this question, but I know that, that LCB takes their deadlines quite seriously. So I would not recommend missing a deadline.
Well, then I just like to request, if it's okay, that we have till the end of today to get you any feedback, so it could still hit the deadline, Melinda.
Absolutely. Thank you.
Yeah, that sounds good. Anybody else, please keeping in mind the deadline? If somebody has not had an opportunity to review it, then let Melinda know so she knows who else may have had any thoughts on this. If nobody else, then Commissioner Bond will get back to you, Melinda, right, Commissioner Bond?
Thank you, I appreciate it.
All right, no problem. Thank you. And then going on to the next item, the discussion of drafted PPC health equity plan requested for feedback from the commission for posting on PPC website. Do we have Kylie Danner on this?
Yes, so I would like to hand it over to Kylie Danner to lead the discussion on all the feedback that was received from the commissioners prior to today's meeting in regard to the draft PPC Health Equity Plan. So Kylie, please go ahead.
Good morning, everyone. My name is Kylie Danner, and I am the PPC Policy Analyst. Each of you should have received a copy of the draft Health Equity Plan, and I would like to discuss some of the recommendations and feedback we have received. Next slide, please. On slide 2, we received some recommendations to clarify the definition of health equity and of health, and to remove slide 3, as slide 2 now incorporates this information. Does anyone have any questions or opposition to this revision?
We don't hear any.
Okay, next slide, please. On slide 5, it was recommended that we include a general summary of Nevada's health disparities. And on slide 8, these questions were posed by a commissioner, and I wanted to pose them to the group. Does anyone have any ideas for specific steps to ensure there aren't any unintended consequences or inequities as a result of the cost growth benchmark?
Any commissioners have any comments?
Yes, Commissioner McAllister.
I didn't pose the recommended edit, but I like it. And I think one of the steps is to continue stakeholder engagement to make sure that we're getting feedback from different groups on their thoughts on what the steps may lead to.
Absolutely. Is there anybody else?
Commissioner Winkler.
Thank you very much. This was my recommendation, along with ensuring stakeholder feedback to also take efforts to get just general public feedback as well, make ourselves more accessible and available to patients in Nevada so they can let us know what's going on, what they're experiencing.
Thank you. And any other comments before we move on?
Seeing no other hands raised, Chair.
All right, thank you, everybody, on this subject. We can move on to the next item, number 6. Nevada's health insurer rate review process. We have our insurance commissioner, I believe, Barbara Richardson, with us.
Hi. So can everybody hear me, I hope?
Yes.
Okay, so I would like to say I'm sorry I missed the last PPC meeting because I understand you all were discussing the division's rate review process and you had some questions for us. I have just a few slides, but I have a lot of information. So I'll try to speak quickly because I know there's only 15 minutes and there's a lot of information and I'm sure you're going to have more questions after I present. So first off, I'm going to provide an overview of the current Nevada Division of Insurance rate review process. And this is for the fully insured health benefit plans. And then I'm going to hope to address some of the commission's general questions after that. So let's go to slide 2. So let's start with our updated projections for health payer sources in Nevada. So this information comes from a variety of sources as there's no one definitive set of data that provides an annual look at the Nevada health insurance market. So once a year, the division compiles the latest data from the same set of reliable data sets to create a picture of the current health or current state of the health insurance market. I do know that the state of Oregon has figured out a way to get this data. It is through their organization that's much like the PPC, not through any of the regulators or, not like DHHS or the insurance division. So I don't know if that's something you guys might want to think about to help give you a clearer picture of what's going on. So based on the information, as you can see, for carrier filings through the National Association of Insurance Commissioners, you're going to see that at the end of 2021, approximately 130,000 Nevadans were covered in individual market, both on and off the exchange. 83,000 were covered in the small group market. So this small group market represents employer plans with 2 to 50 full-time equivalent employees. And this is both on and off the exchange. And lastly, 380,000 are in the commercial large group market. And finally, according to the Kaiser Foundation, which is where we get our information for the employer self-funded plans, roughly 1,122,000 Nevadans are covered through this type of plan. So slide 3. So this pie chart really just gives you a picture of the data segments shown on the previous slide. So as you can see by the slices of the pie, the Division of Insurance has statutory authority to review and approve health benefit rates for the individual and small group markets. And this covers approximately 7% of the state's population. Large group commercial plans account for 12% of the population's health insurance coverage. So slide 4. So one of the things that it's important to know is the timing of individual and small group product and rate review filings is based upon the Federal Affordable Care Act requirements. The individual and small group filings are due to the division during the first week of June every year. As part of the review process, carriers are required to submit numerous templates, exhibits, and documentation to support the proposed rate change, and the entire rate review process must be complete prior to publishing the rates for consumer review prior to the open enrollment every year. So we'll go to slide 5. So to create uniformity in the information that carriers must include in each rate filing, a rate checklist is provided prior to the rate filing season. That's what we call it here. It's like mud season. We live through it. And that includes all the information the federal government, the state, and the division requires for individual and small group filings. Carriers must also include actuarial memorandum to provide specific information related to the filing. And this would also include support for the development of proposed rates, required actuarial certifications, the premium development template, which also has supporting information on the components used to develop the proposed premium, and as well as the Nevada data template, which contains Nevada specific additional filing requirements, which include things like projected enrollment numbers, rating factors, plan mapping, and rate changes, and other exhibits necessary to conduct an independent review of the proposed rates. So the division contracts with an outside actuarial firm under our statutory authority to conduct an independent, detailed actuarial rate review of each and every submitted rate request. The firm that won the contract for the 2023 plan year is Lewis and Ellis. So throughout the review process, Lewis and Ellis and the division staff each independently reach out to the carriers to get clarification of different elements within the carrier's filing. This is to basically maintain the integrity of an independent review. The plan is to have 3 different opinions, all looking at data sets, and to find out whether or not they're coming to the same framework or whether or not there's something off. So the general process that this is called the objections. So these objections period, or the objections period, may relate to incomplete information, insufficient support related to included or not included trends or factors used in developing proposed weights. It could also include anomalies, outliers, or inconsistencies which lack proper explanation or support. There's often several rounds of objections between the carriers' actuaries, Lewis and Ellis, and the division's actuarial teams before a rate proposal is given its final disposition. So it's all probably also probably helpful to know that under the federal guidelines, there is a planned profit factor. And I think this is probably something that folks know about but may not understand. This planned profit is included in carrier rate filings, and in Nevada, it ranges between 1% to 4%. And along with this factor, the filings rate assumptions must reflect medical loss ratio requirements. And that's used to limit overhead, administrative expenses, marketing, and profit. And that's going to be, or that is held under the federal guidelines to be no more than 20% of the requested premiums in the individual market and 15% in the small group market. So then at the completion of the outside actuarial firm and the division rate review, following information is also considered when determining the final approved rates. So move to slide 6. So the carrier's initial rate request, carrier's modified rates if the rate was changed during the review process, the carrier's actuarial team's recommended range of reasonable rate changes and factors, the independent actuarial team's recommended range of reasonable rate changes and factors, each actuarial's recommended rate, the division's actuarial analyst team's recommended rate, a summary of notable rate review assumptions to be considered in the final rate approval. And this may include the anomalies, outliers, and other factors that we found should be considered in rate approvals. An example, these assumptions may also include information on projected risk adjustment, morbidity, projected changes in membership, solvency concerns, and the potential impact on the overall market. So at that point, final rate gets approved and posted on the division's website for consumer input. And then finally, a final rate is approved and submitted to the carrier, the public, CMS, and the exchange. So move to slide 7. And this is all done within a 3 or 4 month period. So as you can see on this particular slide, the approved rates are based on numerous assumptions about future loss experience. So because of that, the Affordable Care Act's medical loss ratio policyholder rebates have provided an important retrospect backstop when a carrier's actual loss experience ultimately creates excessive rates for a plan year. For example, in the years 2019 through 2021, the Nevada policyholders have received the medical loss ratio rebates of $8,680,000, $14,383,000, and $10,443,000 as distinguished by those years from plans where less than 80% of premium income for individual plans and 85% of small group and large group were spent on medical care and health care quality improvements. So this happened because the unpredicted decrease in the utilization of the medical services. And this occurred because the basis, or this based on the effects of the COVID-19 public health emergency. People simply were not going to the doctors much, and they were putting off hospital stays if they could. So slide 8. So I'm going to get now to some of the questions that were posed by the commission members. To start, I understand we're looking to find out some of the positive and failing rates of our current rate review. And I will tell you why I believe that our current rate review is thorough to determine if the approved rates are adequate, not excessive, and are appropriate as required by statute. I realize that might not be what you guys are asking. For example, I do know that, that the division would consider a general failing of the entire process is based around the federal timing requirement. So for example, the timing requirements of the Affordable Care Act are not always practical. For example, this past year, additional subsidies that had been added during the American Rescue Plan Act of 2021 to help consumers were set to expire at the end of 2022. However, the federal government's decision to extend the subsidies as part of the Inflation Reduction Act of 2022 were not made until the middle of August. That meant there was no way to factor in these new subsidies into rate projections that had to be filed in June. So these CMS timelines don't always factor into federal decisions on other issues, and sometimes they can end up affecting rates and can be frustrating. think it would also be helpful probably to know for you all that Nevada relies on competition between carriers to create the downward pressure on network contracts with providers, facilities, hospitals, and pharmaceuticals, unless we need to take into account solvency concerns or appropriate and adequate networks. These situations can result in rate increases to be sure that a carrier has adequate surplus and capital to pay its consumer claims and liabilities. Otherwise, the rates would be inadequate. So one of the questions that I believe was posed by the PPC at the last meeting had to do with the thought behind whether or not the division would be okay with additional authority to strengthen the rate review powers to include the ability to help drive down medical costs. And while focus of the PPC is to figure out how to drive down the medical costs in the state, I did think it was going to be helpful for the commissioner to see where Nevada is currently ranked in comparison to its fellow states on this factor. And this goes back to something that Patrick Kelly brought up. So let me post this on here. So I just put a link in the chat feature to a recent Forbes Advisor research project, which has some of the same information that Patrick Kelly was chatting about. And as you can see, Nevada was ranked 49 out of 51 in ranking from most expensive to least expensive in healthcare expenditures per capita. So this is one of the times where it's good to be at the bottom end of the number range versus where we usually are in Nevada's in trouble because we're the lowest of the low. So Nevada ranks 4th in the nation for the lowest healthcare expenditure per capita. Nevada healthcare cost average, and I believe this is an updated number from what Patrick may have given you, $8,118 per year. And only Utah, Idaho, and Texas have lower per person health costs. That doesn't mean we can't still consider how to drive down health costs, but it's always good to know where you're starting from. So Nevada also has the 3rd lowest increase in overall healthcare spending per person over the 5-year period. And this is behind only District of Columbia and North Carolina. But keep in mind that the healthcare numbers aren't always positive. And if you look underneath some of the data, you're going to see that the state had the 11th highest percentage of adults who delayed care over the past 12 months because of cost. And that's about 13.3%. And that is an issue that I think would be really important for the PPC to be thinking about, is trying to figure out if that is due to higher deductibles or what's driving that, that particular issue. So the last question on the slide is about the Division of Insurance ability to take on additional rate oversight to include the large group market in Nevada. So before I answer that, I thought it'd be helpful to understand why Rhode Island, which is an example of a state that created that type of regimen, may have done so. So the state of Rhode Island does not have a competitive market due to the size of the state. So they created the Office of Health Insurance Commissioner and have mandated affordability standards to encourage insurance carriers and hospitals to reduce costs by creating more efficient systems, and have modified their statutes to require insurers to increase the amount of expenditures that are spent on primary care providers. And they have adopted payment reforms promoting population-based contracting. In taking on these duties, Rhode Island's Office of Health Insurance Commissioner is made up of 10 staff above and beyond what is in their state's general insurance division. Rhode Island does review and approve rates for the large group market, and the large group rating is different than the individual and small group rating. The small group and individual rates have a single risk pool, so approved rates apply to each purchaser of those plans. Large group plans are heavily weighted towards the actual loss experience of each group. So 2 employers with identical ages and numbers of employees could pay vastly different rates to pay based on their loss experiences. So that's something to keep in mind when you're looking at the way types of programs are actually, the rates are determined. Large group plans follow much of the same rules as the federal ERISA laws. So plans are not required to include any or all of, or excuse me, they're not required to include all of the essential health, but they usually have some. And Nevada's been pretty lucky that most of our large group plans like to pick off the shelf products. So the bulk of those in the commercial market are using essential health benefit plans. So one of the reasons why the average rates in the fully insured market could be less than the small group and individual plans is because if they do not use all of those benefits, they may be giving a lighter product, or what we call not a rich product, to their employees. So go to slide 9. So for large group, the Rhode Island Office of Health Insurance Commissioner reviews the average expected percentage change in premiums from one year to the next, holding benefits constant across all employers that are up for renewal within a given market. Their approved average expected premium increase per carrier are comprised of rate factors that apply to the employer's existing experience. The resulted weighting average increase across an insurer's large group market represents a maximum average rate increase that the insurers are committed not to exceed. So if an insurer's approved rate increase for the year was 9%, the insurer is expected to hold their overall rate change compared to that previous year to 9%. However, the rate change to individual employers could be vastly different based upon the individual employer loss experience. Slide 10. Oh, so why don't we go back one more? Because this one's going to give you some more information that might be helpful. So the slide also provides a comparison of Rhode Island large group experience compared to Nevada's. The average premiums per member that are reflected on the slide are based on the total large group written premiums divided by the number of covered members. It also allows for a comparison of average rates and average percentage change in premiums paid from year to year. So the average premium increase in the Nevada large group market during this 8-year period was 4.303%, and this is compared to 3.75% in Rhode Island. Again, I just want to emphasize that one of the reasons why Rhode Island really needed to go this direction is that it only had, well, it has a couple of carriers, but there's really 2 carriers that make up 91% of their large group market. And one of those carriers has close to 80% of the state's total market share. So higher regulatory scrutiny is always needed when a market is close to a monopoly and there's not sufficient competition to encourage cost controls and competitive pricing. And we don't see that same issue here in Nevada. So that's just helpful to know as you're considering what you want to do. So that's with that, I'll end my presentation. So move on to the question slide, and I'll be ready to answer any questions. Hopefully I didn't take up all my time.
This is not a just a quick one-liner. Does your population include, submitted for small groups, large groups, etc., include the ERISA membership also?
So the ERISA membership, are you talking about the small group level funded plans and the association health plans? So those would be under the Department of Labor.
So your data doesn't include the ERISA data?
No, that is the ERISA data. It comes from the Department of Labor.
Oh, okay. All right. Thank you.
It's just so tiny, honestly, in Nevada. It wouldn't make a slice.
Okay. All right.
Yeah.
Thank you.
Yeah.
Anybody else has questions?
Yes, I'd like to go to Commissioner McAllister.
Thank you so much for that presentation. I took so many notes and I'm already planning on rewatching the recording later. That was great and a lot of good information. I have 2 questions. Your very first slide, you were talking about how the Patient Protection Commission in Oregon is collecting this data. Is that something you would recommend in Nevada that we work on, that we help you to get the data so that you can look at the plans more easily and not have to go to multiple sources? And then my second question is, have you thought about what impact the public option might have on rates in the state?
Sure. Yeah. So first, let's talk about the Oregon issue. It's not just us. It would be DHHS and it would be you. Really, it's gathering that kind of data is just helpful to have so that you can make decisions, because right now, yes, we trust each one of the sources that we get, but they come out at different times of the year. So you're always cobbling these approximations together. And I think, you can, if you misstep and you put like 2 years ago's information or a year ago's information for one of your pie slices, you don't get a consistent picture from year to year. And we've tried very hard to create a situation where we'd have a consistent picture, because it would really alter, especially because of the growth of the population in Nevada, if the pies weren't using the same underlying data. So yeah, it's not collected by any of the divisions or the DHHS in Oregon. It's really collected by that separate group. just for making sure that they have data to make determinations. And as far as the public option goes, I don't really have much to say on the public option, other than right now, I think the concern that we've been looking at is that that they're talking about having the second lowest silver plan be the determining factor. And the only concern with that is that the second lowest silver plan, whatever that is a driving or used as a bellwether for other plans, and how much the federal government will give back to us as a state, how much the risk adjustments cost or provide back to the consumers. So sometimes being that spot, it's a bigger burden than I think that people understand currently. So, but we're still years from sort of working out that piece of it. But that's going to be my only concern, is having that be as the bellwether. Thank you.
Any other questions?
Yes, we have two more. So Commissioner Bond, please go ahead.
Thank you, Commissioner. I have one that was just raised by what you just responded to Commissioner McAllister. For us to change anything about the public option is going to take legislation, right? I mean, I know we're years away from implementation, but the legislation's written, and it's written with things like the silver plan. So there would have to be legislative remedy for us to change the public option at this point. Is that not correct?
That's correct. Mm-hmm. Okay. I think that's why, for me, that's a policy decision that's outside of my, yeah.
Yeah, so I mean, that might be something that this commission wants to consider in the future, is what would help the public option be a better product for Nevada, because I think, personally, there are flaws in the bill that we're working with now. But my actual question is it possible, based on everything you just said, to get a percentage of the carriers' control of the market? You're saying that it's not like Rhode Island, that Rhode Island only has 2 carriers and one of them has 80% of share of the market. But in Nevada, we have a few carriers, but I think that it's not evenly distributed in terms of market share. Do you have the capacity to create a chart that would show us market share by carrier in the small market and the large market?
To be honest with you, I think we already provided that to Baylett. The top 10 carriers is what we did, because as it gets smaller, it's again, you run into situations where the slices aren't big enough.
Okay, I think that would be great if we've got it, to have that distributed to the coalition, so we understand. I'm sorry, the commission, so we understand a little better about who the players are here. Thank you.
Thank you. Any other questions?
Seeing none, Chair. Oh, hang on one second. I do have a Commissioner Ralston. Please go ahead.
Hi. Sorry. I just actually, when we were having our discussion, one of the things that really occurred to me when we were talking about the most and least expensive states for healthcare, and the article that Commissioner Richardson stated, and also I believe it was Patrick Kelly that mentioned in public comment, it just occurred to me that I would be remiss that if I didn't speak up and also say that we need to take that in context to the average household income for constituents here in the US, and Nevada is well below the average household income. And so even though if it looks like it's okay in some aspects, I really encourage all of the commission members and everyone watching and the patients to keep into context that what can the average patient afford here in our state, because we are well below the household average in the US in general. So just wanted to throw that out there. There was no question, it was just a comment, because I just want to make sure that having more information and more data as we're looking at all of this is really important for context.
Thank you. Commissioner Alston, any other questions before we move to the next subject?
Yes, just one more, Chair. Commissioner Bond.
Hi, thank you. I'd just like to follow up on that. I appreciated the public comment today, but I do think there should be a comprehensive conversation. If public comment is presented and then just left there, we don't really follow up much. But I do think that one of the things that's not considered in the data provided by the commissioner or the comments today in public comment is that as a percentage of profits that are tied to these providers. And I think we could really break it up between the hospitals and and the physician provider communities. I think the hospitals do really well in this state, and I think the profits are invisible when you see the kind of data that we're looking at right now.
Thank you, Commissioner Bowen. Anybody else you see, Melinda?
I see no further questions, Chair.
Okay, we go to the next item 7 for possible action, prioritization of cost growth mitigation strategies. This is Michael Baylett.
Sure. For this one, I just wanted to quickly introduce this topic. So both in September and October, Baylett Health has presented overviews of 4 cost growth mitigation strategies, also are summarized in a handout for your meeting materials today. So these include provider price caps and or price growth caps, prescription drug affordability strategies, strengthening and expanding health insurance rate review, and promoting multi-payer value-based payment. So all 4 of these strategies are informed by the phase 1 cost growth driver analysis using both Nevada Medicaid and PEP data, which shows that prices are driving high spending growth. So these strategies all have the opportunity and intention of helping Nevada keep healthcare spending below the cost growth benchmark. When considering this agenda item, we are looking for consensus, meaning can you live with identifying one or more of these strategies being presented to further explore and potentially eventually pursue as an official recommendation to the governor and the legislature. So just looking for what you would like to explore further in this agenda item. To help with the potential decision point today, the following slides and presentation will outline a brief recap of each cost growth mitigation strategy, plus provide a summary of commissioner feedback and questions that have been received to date, and provide an assessment of the feasibility of implementation in Nevada. So with that, I wanted to hand it over to Michael Baylett to take it away.
Thank you, Melinda, and hello, everybody. I think Melinda covered that these are the 4 strategies that we've talked about so far. They're all informed by the phase 1 cost growth driver analyses that you had presented to you in April. It showed prices are the primary driver of spending growth in the state. I think that Melinda covered this. So let me go to the first one. First one is price growth cap and price growth cap. I'm going to briefly summarize it. So as a reminder, and for those of you who were not at the meeting when we discussed it, the provider price cap is a limit on how high provider payment rates can be in the commercial market. The cap can be linked to market averages, to Medicare prices, or another external reference. And the cap can be applied very broadly to all in-network and out-of-network care, or much more narrowly. Some states have done this just for out-of-network payments. It can be done just for specific types of services, or just for specific programs, such as state employee benefit programs, which is what Montana and Oregon has done. In contrast, provider price growth caps are limits on the amount that insurer prices can grow to providers annually. A provider price growth cap can be applied to all contracted providers, certain classes, such as hospitals, which is what Delaware and Rhode Island have done. So these are 2 separate concepts. They can be pursued simultaneously, but they're different. One is capping outlier prices, and the other one is capping the rate of growth. Both of them would have impact on affordability. The second one links much more closely with your benchmark, which is a per capita growth target. So when we talked about this previously, there was a fair amount of discussion. I would say there was mixed sentiment on it, but a desire to learn more from Montana and Oregon and what they've done with their price caps, and for Rhode Island and what they've done with their price growth cap, and how they've used rate review as an enforcement mechanism. I would be remiss if I didn't note that there was also some concern that this might impede access, although as we saw recently from the patient survey, already it appears that almost 6 out of 10 Nevadans are not accessing care because of high costs. So I would say to some extent we already have access problems, but it's fair to the question, would this in some way impede future access? So potential next steps would be to invite presentations from these other states that have pursued these strategies. And the last thing I want to do is provide a feasibility analysis. Commissioner Tyler Garner at the last meeting asked for an assessment of feasibility. So I want to share it first for the price cap and then for the price growth cap. So this is a quick high-level synopsis. So I'd say for price cap, political feasibility is challenging because it is likely that whatever provider type might be targeted through the cap would strongly oppose the cap. Okay, that's probably not a surprise to anyone. In terms of financial and administrative feasibility, here the implications in terms of implementation work and administrative complexity is pretty low because the strategy is a pretty simple one. And whether it's administered through purchasing authority and or insurance regulation, it's not all that complex. In terms of impact, it can be significant, but it depends on where the caps are set and how broadly they're applied. So the higher the caps and the narrower the application, the less impact, obviously, and the converse. Price growth caps really have the same political, financial, administrative assessment for feasibility, challenging politically, but not all that difficult to implement. The impact here is likely to be a little bit higher on cost growth. But again, it depends on what the price growth cap is set at and how broadly it's applied. Right. So this is a summary of these first really two strategies. We've grouped them together because the concepts are similar, but really two separate strategies. So we're going to go through all four of them like this, and then we'll pause and ask you whether you want to prioritize any of these for further exploration. So the next strategy is really a class of strategies, prescription drug affordability strategies. I in work with another state where they've got they convened a work group just to focus on this. Our initial meeting generated 15 different potential strategies that fall under this umbrella. So when we discussed it today, we spoke about it just broadly, and my colleague Alyssa is going to review this book.
Thank you, Michael, and hello, everybody. Nice to be with you today. So as Michael said, I am going to cover the next two topics, the first of which being prescription drug affordability strategies. When we presented this information to you previously, we noted that we were focusing just on strategies to address prescription drug costs in the commercial market, not outside of the commercial market. And the strategies that we presented fell under two major categories of proposed approaches. The first approach being one that involves the regulation of prescription drug payments, meaning what a purchaser pays for a prescription drug. And the two specific strategies under that umbrella would be one, you could create a prescription drug affordability review board to conduct affordability reviews for particularly high price drugs or drugs that have experienced significant price increases over a period of time. And then that board would be given the authority to establish an upper payment limit, meaning the maximum amount that any purchaser or payer in the state would pay for that particular prescription drug. A alternative but somewhat similar strategy would be to use international reference pricing to establish upper payment limits based on prices in another country or countries. And we discussed that one model uses the reference, bases the reference price on the lowest price in the most populous provinces in Canada. So those are those two strategies. The second approach would be to impose penalties on excessive drug prices. And that could also be done in a few different ways. One is that drug companies could be penalized if drug price increases are unsupported by new clinical evidence. And one existing way to assess that is based on an annual report put forth by ICER, which is the Institute for Clinical and Economic Review, that assesses whether new drug, basically high cost drugs, have price increases that are supported by new clinical evidence, as well as safety and efficacy. And then another approach would be to establish a penalty if drug prices increase a targeted growth rate, such as inflation plus a specified amount. So again, these are 4 different strategies under 2 different sort of umbrellas of approaches that we talked about previously. In terms of feedback from the commissioners, I would say that we felt that there was some general interest from a number of commissioners in some of these strategies, given the role of prescription drug spending in the state and how it is a significant cost driver, as well as some of the data we presented on the affordability survey, where Nevada residents have reported challenges with affording prescription drugs. There was interest from multiple commissioners in learning more about the international reference pricing strategy, as well as thinking about some comparators in addition to or aside from Canada. There was some concern presented about the proposals to impose financial penalties, and there was a request for information on potential legal challenges that could be anticipated for any of these proposals. So if the PPC opts to further pursue exploration, one or more of these strategies, we would recommend that NASHP, the National Academy for State Health Policy, could be a good resource in presenting further information to the PPC. They could focus on international reference pricing. They have model legislation based on that, as well as discussing anticipated legal challenges, and they could also provide further information on any of the other strategies that we presented. Moving on to the feasibility analysis component. As you can imagine, the feasibility varies significantly based on which of these strategies would be pursued, but high level here, political feasibility we anticipate would be challenging due to the likelihood of strong opposition from the pharmaceutical industry. In terms of financial feasibility, meaning costs for the state, if the state were to pursue a drug affordability review board, that could entail high implementation cost. If a new board were to be set up and staffed and had to undertake new affordability review. If the upper payment limit international reference pricing approach is pursued, that would mean lower financial costs for the state, because one could rely on those existing international reference prices as opposed to setting up a new body. And then the strategies around penalizing excess drug prices could be medium to low cost for the state based on how those are administered. Similarly, in terms of administrative complexity, a drug affordability board would be more complex to establish if it's a brand new board with new duties, lower complexity for international reference pricing, and medium to low complexity for penalizing excessive drug prices, again based on how those penalties are established and what triggers them. And then in terms of the potential impact on slowing healthcare cost growth, if a drug affordability board were to be pursued, the impact would depend on the number of drugs impacted by affordability reviews, and it could be low based on the amount of time it would take for a board to go through an affordability review and determine if an upper payment limit should be established. If international reference pricing were to be pursued, the impact could be medium to high, again, also based on the number of drugs subject to the upper payment limit. And then in terms of penalizing excessive drug prices, that would be low to medium impact based on the number of drugs that would trigger the penalties and the amount of the penalties. So that is a synopsis of prescription drug affordability. Moving on to the next topic, health insurance rate review. So I'll go through this quickly, as you already received today an overview of how this process works in Nevada by Commissioner Richardson, which was very helpful, I think, for all of us. As you know, the Division of Insurance approves, disapproves, or modifies proposed rate increases in individual and small group plans. And Commissioner Richardson discussed that some of the requirements of the Affordable Care Act that are currently in place governing the process in Nevada. We talked at the last meeting about potential mechanisms where the process in Nevada could potentially be amended. And I think you all heard today from the commissioner some thoughts on how those processes are currently working and whether or not they should be amended. So moving on to the next slide, feedback and questions from commissioners. Again, This is information that that was discussed just previously, so I won't go through it in detail, but I'll just say that we would encourage the PPC to consider how the insurance commissioner's feedback presented during today's meeting would impact further exploration of the strategy, including any sort of interim, questions that would need to be further explored. And lastly, for the feasibility analysis, politically, this could be challenging based on the level of opposition from the health insurance industry. The financial feasibility could be low to medium cost for the state based on mechanisms pursued, noting that, for example, expanding review to the large group market could entail additional resources from the Division of Insurance, or holding a public hearing or public meeting in conjunction with the existing transparency processes could also entail further resources. Administrative complexity would be to medium based on the mechanisms pursued, recognizing that the current, potential changes would be built on an existing set of processes that are already in place. But again, depending on if additional changes were to be pursued, that would depend on that would impact the administrative complexity. And then the impact on slowing healthcare cost growth would also vary based on which, if any, changes were to be pursued. Adding additional affordability and public interest criteria may result in lower premium increases for the small and individual group markets. Expanding the group market may result in lower premium increases for large businesses and their employees. And additional transparency through public hearings could help put additional downward pressure on premium increases. It is, however, challenging to quantify what these impacts would be. So I will pass it back over to Michael now to talk about the remaining strategies.
So a quick question, this is Dr. Khan. What is the percentage of healthcare costs related directly to prescription drugs? If we are spending $100 on total healthcare, what percentage is prescription drugs?
So Chair Khan, it depends on the market.
In Nevada.
Yeah, we have data only for PEB because without an all-payer claims database, we don't have access to broader data. I don't remember what it was from the April report, but we can share that information. Bobette, you know, for your plan?
Thank you.
Why don't I, even though ERISA plans, which the Culinary Health Fund is one, don't provide that data publicly generally, I would be happy to pull that together and present this or provide it to you, Melinda, for the coalition. I think it's really, for the commission, I think it's really important that you see something in writing. And this is our #1 cost trend. It's not our #1 cost, but it's our #1 cost trend. It's increasing faster than anything else. Maybe not this year, but previous years. So I want to go check that, but it is our #2 cost overall in our drugs, in our healthcare spending. And I'll get you more data about it. And I will ask the coalition if they're interested as well in providing their pharmacy data voluntarily for the purposes of evaluating this. I think we've got to try to do what we can in the state about prescription drug costs.
Yeah, thank you. That's very helpful, Commissioner Bond.
Yeah, I will share that my experience across multiple states is that in the commercial market, it's approaching a quarter of total spending. So I would guess that we're going to find something 20 to 25%. And growing. And I should say further, 20-25% if we look only at retail pharmacy. If we look at the medical pharmacy, the infusion drugs, sometimes referred to as the Part B spending, that's going to tip it up a few additional points. And that spending is growing much faster than even the retail spending.
I agree. We could try to get inpatient as well.
Thank you. I think you may proceed.
Okay, our last strategy that we discussed is multi-payer value-based payment. Value-based payment is a strategy by which healthcare purchasers and payers link performance on quality and management of total cost of care to payment. And advanced value-based payment models involve some element of risk transfer to provider organizations for assuming responsibility for hitting quality and cost growth targets. These models can potentially slow the rate of growth by applying a budgeting mechanism to payment. We'll say that the budgeting mechanisms that involve some degree of risk transfer are likely to be more effective in slowing the rate of healthcare growth than those that do not. Value-based payment models are most effective when there are multiple payers across the commercial Medicaid and Medicare market that are pursuing common model elements. So it doesn't have to be the exact same payment model, but to the extent that there's more alignment, then the economic signal to provider organizations is clearer and more compelling. So when we spoke about this previously, there was interest in understanding whether this would have detrimental impact on vulnerable patients and what could be done to protect against adverse impact. And there was also interest in learning about experience with value-based payment models in Nevada and what has and hasn't worked. So possible next steps could include a presentation from Medicaid and or other both payer and provider entities in the state with experience implementing value-based payment models. In terms of feasibility, so, as with everything, it depends on how this is done. I would say in general, this is less likely to generate the type of strong political opposition of the other strategies, in part because this is, depending on how this is done, this is not necessarily going to be quite as effective in slowing cost growth as the other strategies. So there is obviously, or maybe not obviously, but there is an inverse relationship between political feasibility and the certainty of impact in slowing healthcare spending growth. Okay, probably not shocking to anybody here, but I'll say it for what it is. Financial administrative feasibility. This is at least medium because coordinating a multi-payer approach to doing this work requires a lot of process facilitation, and it's not always easy to get payers to agree to do things in an aligned fashion. So I'd say medium to high for this particular strategy. And the impact depends on the model being selected. This is an approach that two other cost growth benchmark states, Oregon and Rhode Island, are pursuing. They both have their payers and providers agree on compacts and targets for implementing these models. So there is some experience doing it, and it is possible, but you need a lot of collaboration across payers, providers, and government for it to happen. So those are the four that we've discussed. These are not the only potential strategies for cost growth mitigation, but these are four that that directly or indirectly might have impact on price, which is the primary cost driver in Nevada, which is why we shared them with you. And so pulling it all together, as Melinda previewed a while ago, we want to ask you, which, if any of these, are you interested in exploring for further, for potential prioritization in 2023? And the opportunity is open to identify any other strategies beyond these four. And Melinda, I'll let you recognize the raised hands.
Thanks,
Thank
Michael.
you, Melinda. Let's recognize the commissioners who may have comments or questions.
Thank you, Chair. We'll go ahead and we'll start with Commissioner Winkler.
Hello, Commissioner Winkler, and thank you very much for providing those summaries and specifically the breakdown of feasibility and potential impact. However, I really want to know, to the degree that we're able, with these strategies and any more strategies we might explore, the potential impact on health outcomes, health equity, affordability, and access for Nevadans. Definitely, this is part of our commission to look at slowing healthcare cost growth, but I also want to know if implementing these strategies are going to help Nevadans in a way that they can understand. That's kind of like my big one there, but otherwise I'm interested in exploring all of them.
Thanks, Commissioner. We'll next go to Commissioner McAllister.
Thank you so much. And I second what Commissioner Winkler just said, that we need to also have a review of what kind of impact this has on health equity. But of all the strategies presented, there are two that I feel are worth exploring further. So regulation of prescription drug payments with the international reference pricing. I think we should look at more deeply for Nevada. And then the provider price caps. And I'm specifically interested also in if the other states are only doing those caps for people who live within the state, so it wouldn't impact health tourism, right? So if they don't live here in Nevada, do we really care how much they pay for a knee replacement?
Thank you, Commissioner. We'll move along to Commissioner Ralston. Okay, Commissioner Roe-Dugan.
I think Sarah was just
Yes.
muted. I think she's talking but muted.
Right.
Oh,
Sarah.
no. I'm so sorry, guys.
Sorry, I'm technically challenged this morning. I meant to unmute, but I lowered my hand instead. And so I just wanted to say I really appreciate the summary and the work that you put in for this presentation. I echo the comments of my fellow commissioners. I am wholeheartedly interested in exploring all of these options for further discussion. I think it's totally within the jurisdiction of this commission responsibilities to have these deeper dive discussions about what are the next steps, what could we do. I think, we just started with the all payer claims database, collecting data, having information. I think this is the next natural step to take each one of these topics and have a deeper presentation to the commission and a deeper dive on all of these issues. And especially, I think it was Commissioner Winkler who mentioned, kind of the Nevada component. Even in the summary, my initial perception is that I want to have, an entire meeting dedicated to this one topic. And I would like to add the layer of the Nevada perspective. What are we doing now? What have we seen as challenges in the past? What does the legislative landscape look like, in 2023? I think even if we have these discussions in January, February, March, or April, we could have that Nevada component about kind of legislative pieces, historical and future. And I think it really warrants our entire attention for each topic and really making sure that we think about how we help Nevadans on each part. So I support all of these and I support them for 2023 and having deeper dive discussions. And then potentially even talking about breakout subcommittees for each one of these topics if they're necessary too. So I'll leave it at that. Thanks.
Thank you, Commissioner Ralston. Anybody else?
Yes, Chair, we have a couple more hands raised. We'll go next to Commissioner Roe-Dugan.
Thank you so much, Melinda. So I would like to say that I also agree with Commissioner Ralston and Commissioner Winkler. I would like to hear more about all of the strategies, but specifically would like to concentrate on making sure that we are putting the patients first and making sure that there is equity and access with all of these mitigations, that there is not going to be unexpected results that will affect the patients.
Thank you, Commissioner. We'll go next to Commissioner DeServo.
Thank you. Yeah, just to be brief, it kind of sounds like the group is coalescing around all four strategies looking further. So I guess just to lend my thoughts from the pharmacy perspective, I'm relatively opposed to the prescription drug affordability strategies. I don't see in the current way it's listed much kind of fruit to bear there. So I guess that one is one I'm less interested in, unless we add PBM reform regulation looking into that strategy. That's kind of the new way many states are going. We've had the recent Supreme Court case allowing PBMs to be regulated on the state level, and that really seems to have high potential to drive down prescription drug prices rather than the other strategies listed on the slide. So I guess supporting the others, coalescing around all four, I'd be with that. But unless we add PBM reform as one of the prongs to look at under the prescription drug affordability, I would not support a deeper dive on that.
Thank you, Commissioner. Move on to Commissioner Bond.
I do not agree with what Commissioner Dershowitz just said, but I totally agree with what the other commissioners have said. I think that if we could do it the way that Commissioner Ralston just suggested, where we take one topic every meeting and try to go through it in some more detail and get the materials ready for how to work through, the impact on Nevada, I think it would be really helpful. I don't think there's anything here to take off the table. I just don't see a reason to take it off. On prescription, on PBM regulation, I think that there's a lot of controversy around that. But I know after 4 years of trying to work on prescription drugs in this state, we need all the help we can get. And I think this commission should consider things that actually go to the heart of the problem, which are the prices.
So thank you, Commissioner Bond. Just my quick comment on that. I think I'm in agreement to do some deep diving that Commissioner Ralston and Commissioner Bond mentioned. Melinda, if you could kindly do some homework to allocate some time on our meetings next, probably in January, so that we can deep dive in each area and come up with our thoughts collectively and vote on it if we have to, or consensus either ways, and narrow things down. That would be my suggestion. Melinda, if you could kindly work and allocate time so that we don't spend a whole meeting of 3 hours on this in one day, but at least one item at a time.
Absolutely, Chair. Happy to do that.
Okay.
Additionally, I do want to recognize Commissioner Tyler Garner has her hand raised.
Thank you. I've placed my comments in the chat and want to say that I concur with Commissioners Bond, Winkler, and Ralston. Support the deep dive and with a commitment to taking or some action or adoption of one or more other proposed strategies. Thank you.
Thank you, Commissioner. Any other comments from the commissioners?
If not, we can move on to our next item. I guess we are on item number 8 now.
Okay.
On the agenda, implications of inflation for assessing cost growth benchmark performance options. Again, Michael Bailett.
Yes, thanks, Chair. And I do want to just quickly introduce this topic as well, if I may. So Chair Khan has requested this introductory conversation led by Bailett Health about the implications of inflation when assessing performance against the healthcare cost growth benchmark. So we will continue this conversation in the coming weeks if there is expressed interest from the Commission. Included in your meeting materials for today is an overview of 5 potential options for responding to the pressures of inflation. I've grayed out the cells in options number 1 and number 5. As per the Chair's request, our introductory conversation today will only surround the middle 3 options. You all are welcome to bring up any alternative options to the 3 being presented today if you feel very strongly the Commission must discuss in this roundtable. So with that, I'd like to hand it over to Michael Bailett.
Thank you, Melinda. As I go through this information with you, if you have questions, please don't hesitate at any point to raise your hand. You need not wait until I have finished. So what is inflation? Just so we're starting with a common understanding. Inflation is a measure of how much prices for both goods and services grow over time. There are multiple indices that measure inflation, and the adoption of the index should match its intended use. The cost growth benchmark, which used potential gross state product, which is a forecast of future state economic growth, uses an inflation measure termed personal consumption expenditures, or PCE. So you see the definition here. This is a survey, it's survey-based information from a survey of businesses, and it is the measure of inflation that the Federal Reserve Bank uses when setting monetary policy for the US. Little context for inflation. So when the governor issued the executive order establishing the cost growth benchmark, the methodology for establishing the value was a weighted average of forecasted median wage growth and forecasted gross state product or potential gross state product. So inflation was embedded in the gross state product value, and the value that was embedded in it was the long-term forecast for inflation, which is the Fed's target rate, which is 2%. And you can see the cost of benchmark values reflect a shift in weighting from heavily on GSP or PGSP because it's long-term forecast to weighting more on median wages over time. The executive order said that the PPC may recommend changes to the benchmarks or changes to the manner in which benchmark performance is assessed should the PPC find there have been significant changes to the economy. I think it's fair to say that there have been significant changes to the economy. So you've been directed that you can, although you're not obligated, you can recommend changes, both to the benchmarks or to the manner in which benchmark performance is assessed, which are two different things. What do we know about the relationship between inflation and healthcare spending? We know they are related. So this is an analysis that looks at inflation, gross domestic product, and healthcare spending. And you can see they map pretty closely to one another. What else do we know? We know that inflation specifically, while it relates to healthcare spending, it does so in a lagged manner. That is, you don't see the impact on healthcare spending after inflation rises until a period after inflation has risen. And in fact, research has shown that the impact is seen over 2 years. And the reason for that is the prices for healthcare services do not change as soon as inflation jumps up. Commercial payer prices are often set in multi-year, 3-year contracts. And public payers, Medicare, Medicaid, set the prices prospectively, but they don't change them frequently in all cases. So you don't begin to see the impact of inflation until inflation has impact on both commercial and public payer prices. So that's why we've got this lagged impact. So inflation, as you all know, has climbed dramatically since about a year ago. This is a graph of inflation using PCE, which is the measure that's embedded in part within our benchmark calculation. Healthcare prices, however, have not risen at the same rate. So you can see here in this graph that only in this past summer did healthcare prices begin to rise. And that's because of that lagged impact that I was talking about. Okay, so other prices have risen much faster than healthcare prices. So in summary, inflation impacts healthcare spending growth. There's no question about that. The impact is not immediate. We know that general inflation using PCE as a measure is at a higher rate than it's been for a couple of decades. And healthcare prices have grown at slightly elevated rates the last few months. And it's fair to anticipate, based on the lagged impact that's been observed in the past, that there will be elevated growth into 2023. Finally, there is anticipation that general inflation is going to significantly drop in 2023 as the Fed continues to raise interest rates. And in fact, we saw a little bit of a dip last month for the first time, but the rates are still very high. Okay, so that's a little bit on inflation and healthcare spending. Any questions before I talk about what might be some options for addressing inflation with the benchmark? No? Okay. So I'm going to present 3 options. You received these in a table prior to the meeting. The first one is don't make any adjustments to the benchmark, but acknowledge inflation when public reporting of benchmark performance takes place and of labor shortages. when interpreting the results. So strength of this, it's consistent with the original intent for the benchmark values to be established for long-term use. And we still have some degree of accountability for affordability during the time period. The cons to this approach is it removes certainty about what the benchmark, what providers and payers are being held accountable to. Okay, and I would say that's by far the most significant one here, is people know that performance will be contextualized. So that's giving some buffer to go above the benchmark in theory, but it's not clear how far. And so this essentially sanctions rates of increased spending growth without a prospectively defined constraint. Option 2 is to create a time-limited allowance for exceeding the benchmark for those years impacted by very high inflation. And so this would be an adjustment that's applied assuming that lagged impact. So for example, the increase in 2022 would show up in 2024's benchmark as an allowance. So this maintains the current benchmark values, creates a temporary adjustment that is providing an allowance on top of the values, but doesn't actually change the values. The cons to this is it does sanction increased rates of spending growth. And during a time of high inflation and maybe a pending recession, consumers are already finding themselves financially squeezed. And so if we were to sanction spending growth above the current benchmark rates, that's only going to increase the squeeze on consumers. And while this wouldn't be changing benchmark values, some people might view it as setting a precedent for doing so. And I will note that in general, there's a real tension here between serving consumers and restraining healthcare spending growth and fairly assessing providers and payers. And option 3 is not creating an allowance, but actually changing the benchmark values, but again, temporarily for a time-limited basis. So this would acknowledge the impact of labor shortages and inflation, maintains accountability, but at a higher level. The downside is not only is it sanctioning increased rates of spending growth, but it sets a precedent by changing the benchmark value.
Michael, I have a quick question.
Stop there. Yeah, go ahead.
So, and just to clarify for everyone, this is just looking at the benchmark and the reporting. We have no penalties. So we can always talk again about inflation when we're going to talk about penalties on any of the players. But for now, it's just looking at numbers and rates.
Yeah, right. The only accountability mechanism that we have right now, and you'll recall we had a presentation by Sarah Bartleman from Oregon about accountability. The only thing that we have right now is public reporting of who met the benchmark and who did not. That's it.
Right. And so for that reason, I think I would favor option 1.
Melinda?
I'm so sorry. Commissioner Rowadugan.
Thank you so much. So I second what the commissioner just said. We don't have any we don't have any penalties at this point. So I would lean towards option 1, keep the benchmark as it is, and acknowledge that yes, there was inflation and that's why they had higher costs, but nothing's going to happen. So I think we should keep it as it is.
I want to share a perspective with all of you. I think that there's some value in the other approaches for a very practical reason. The application of the benchmarks in other states that have them, just in practical terms, is when payers and providers sit down to negotiate, especially commercial payers and providers sit down to negotiate on contracts. What they do is they take the benchmark value and they negotiate around it. And remember, they're negotiating for multi-year contracts, 3 years at a time. If the benchmark value is viewed as being too low because of inflation, then it might get dismissed in the negotiation. Whereas if it's viewed as being, somewhat more reflective of what's happening with inflation and input costs for providers, then it's more likely that the insurer and the provider will negotiate a rate around the benchmark value. So my only concern in the first option is it might mean that the benchmark essentially gets thrown out of the negotiation, and hence it loses its powers being a restraint on spending growth. So just a thought for all.
Can I say something real quick? I don't know if my understanding is correct, but the benchmark already includes inflation in it. Is that correct?
So it includes it in part because it's a weighted average. For the gross domestic product measure, it assumes that inflation is 2%. Okay.
So it would only be what is the word? So it would only affect us if we have something extreme like a pandemic, where the inflation is going to go extremely high and then the benchmark is going to be really off.
Right.
Otherwise, it would increase.
But inflation is really high right now. It's way above 2%.
Right, due to an extreme situation that just happened. And we will get over this, and then we continue with the benchmark as it is based on the numbers that we decided for it, right? Well, that's my, if people decide that option one is too extreme and it may cause us to not be part of the negotiations because our rates are too low, then I would lean for option two as a second choice.
Okay. Yeah, I mean, you all should decide whatever you want. I just want to share with you, some insight on the potential implications. But you all, this is your process. You should decide whatever you think about it.
Thanks. I'd like to move forward with Commissioner Van Halling.
Oh, great. Good morning, everyone, and I appreciate the presentation on inflation. And as somebody that runs I consider a major employer here in Las Vegas, certainly feeling the effects of inflation. And I'll say, as I talk to my colleagues throughout the state, but also the country, the volumes are strong, the revenues are strong on the top line, but in our industry, we always try to control the things that we have control over, and those are some of the expenses below the line, things like labor and supplies and food pricing and reagents. So what I'm seeing, I'm a little bit more in favor of option three, considering that there are no penalties at this point, but certainly I think the goal is to have some incentives around that. But I would just be a little bit more in favor of option three, recognizing that we are in some extraordinary times. As a hospital operator, we do feel in real time because of the impact, what we're seeing on supplies and implants and across the board. But assure you that we try to control the expenses that we do have control over. But right now, we're just seeing that outpace the revenues, and which is creating some accretive margins around the country. So I'm just a little bit more in favor of just because we've got to absorb those costs, as Mr. Kelly said in his opening remarks. And it is reality that close to 70% of our payers are on a fee schedule that we have no control over. So it's hard to adjust in those types of situations. So it offers for leaner times for us. But just my comments as an employer running the largest public hospital in the state, one of the largest hospitals in the state, and it's just tough when you're looking at these expenses and you just you're at a loss because there's no alternatives. And then I would say labor has kept up, at least what we're seeing on the inflationary side, the demand for certain specialties, labor, nurses, doctors, anesthesiologists some of our contractual contracts have been really a challenge, and it's been difficult for us. And we certainly do not want to pass that on to the consumer. So we're trying to absorb that as much as possible, but just a little bit more in favor of option 3 for consideration.
Thanks, Commissioner. I'd like to move forward with Commissioner Ralston.
Hi, thank you. I really want to say thank you to Commissioner Van Houweling and for all of the work that your hospital does and for the betterment of the patients. I really appreciate hearing your perspective, especially being a large employer, and I'm very sympathetic to the work that you do and the service you provide to our community. I say that because I actually want to really push and advocate for option 1 that we discussed and really make no adjustments, but really commit to acknowledging the impact of inflation and labor shortages when we do determine the results. I preface that because the reason why I state that is I do think the other 2 options, including option 3, has a potential to hurt consumers more than option 1. Because again, this is there is no penalty for noncompliance. By and large, this benchmark is set in a good faith effort to establish a baseline discussion of where we are in our state. And if it does have a potential to affect negotiations from insurers and providers, I think that is context that the commission should know about, that the public should know about. And if it is cast aside and the benchmark is just pushed aside, that is something that consumers should be aware of. And we're having these deeper discussions and we're establishing a baseline discussion because Nevada needs to do something. We haven't done anything in the past, and all of our efforts here are really around a commitment to saying we need to do something and we need to collect as much data. So I think that I would really advocate for option 1 and making no adjustments, but I do want to make sure that we stay strong in our commitment to reviewing the results and acknowledging the impact of inflation for a later discussion. So those are my comments. Thanks.
Thank you, Commissioner. I'd like to move forward to Commissioner Winkler.
Hello, Commissioner Winkler. Thank you very much for presenting all that information. I actually have somewhat of a logistics question. Do we know when we would actually see data in relation to the healthcare cost growth benchmark and everything that's reported? Is this a year from now, or I'd kind of like to know that. Can you answer that really quickly?
So plans are for you to see a baseline measurement this March, I think, March or April. And the Office of Analytics at the Department of Health and Human Services are right now analyzing data that were submitted this fall by the payers. So you'll see what trends look like prior to the jump in inflation.
Thank you. And thank you for that. I also want to throw my full weight behind option 1. I think any messing around with the health costs growth benchmark really affects the transparency measure that we're trying to do here. We're trying to get all the information out there for Nevadans to see. And I am convinced in the sophistication of Nevadans to be able to know, like, these are current circumstances and to get that information in mind. And I think, as we've said even today, 6 out of 10 Nevadans aren't seeking healthcare because of high cost. I think we don't want to set a precedent that will raise the benchmark, for potential pitfalls and issues. I think we need to see what the information says and present it to Nevadans. I think that's all I have. Thank you.
Thank you. Anybody else? Melinda?
Yes, I just wanted to note in the chat really quickly, Commissioner Tyler Garner did agree with Commissioner Ralston's comments. And then I do see that we have another question from Commissioner Bond.
Thank you. I don't have a question. I just have a comment. I think for the reasons already stated, I just want to also support number 1 for a couple of reasons. One is it took us months to get there. We spent a lot of time going through ways to do this, and undoing it just seems like we're going to perpetually be, reviewing this information inside our limited time together to set the new benchmark with a lot of opposing forces. So I think just number one, for simplicity, and we got the work done. But number two, I think it is really important that we attach the inflation and labor impact to the existing benchmark and the existing floor and the existing marker. But if we keep moving it, I don't think it will ever mean anything in the end. I think we just need one benchmark and have the information that's, temporarily, though seriously, impacting prices and rates and costs, be documented. And I think it should be documented well. I think we should ask for, what really are the labor shortage costs now that are different than the ones 2 years ago, because I've lived here 25 years and there's always been labor shortages. There's always been a nursing shortage. So I think if we're going to talk about labor shortages as a reason to change the benchmark, I think it would be smarter just to understand exactly what the labor shortage costs are. So I want to stick with number one and do some good documentation about why there's differences in a given year. I'm in negotiations with hospitals right now, and they're, any benchmark we have is a start of a conversation, but that's all it is the start of a conversation. And inflation's definitely being introduced into the negotiations.
Thank you, Commissioner Bond. Any other Commissioner Melinda you can see?
Not seeing any at this time, Chair.
Okay. So to summarize, my question here, Melinda, is we've looked at it as for possible action. And the question to commissioners, all of you folks willing to take some action today, or you want to summarize your thoughts and get back to Melinda and sort of in a poll, and we can come to a final conclusion after you've all given your preferences.
Quickly, Chair, I just want to note that this item on the agenda was noted for discussion only. It was not an action item.
Okay, so sorry, you're right, that's my error. Okay, good enough. Thank you for correcting that. I'm looking at it all.
So can I clarify, Chair? If that's true, we don't have to do anything because the current benchmark is item number one, right?
That's correct. That is correct.
Okay.
And thank you, Melinda, for bringing it to my attention. All right, so we're going along to the next item then.
Sounds good.
All right, so we're on item number 9. Is that you, Melinda?
That is me, Chair.
All right.
All right. So as an initial discussion and working towards solidifying a course of action as we head into 2023, I wanted to provide an overview of the priority charge of the Commission thus far in improving healthcare affordability, which is the healthcare cost growth benchmark. Next slide, please. And if you will recall, in the beginning of this project, we used this logic model quite a bit to help orient on the different stages of this continual cycle. Just a couple of quick highlights showing the current and upcoming focus of this project noted on this slide. So we have a focus on the analysis phase with both phase 1 and phase 2 analyses of the Medicaid and PEB data. And just a reminder that the phase 2 analyses are planned to be presented to the Commission next month. So super exciting there. As well as the aggregate baseline benchmark data that Michael had just mentioned that is undergoing verification and analysis by our Office of Analytics team right now. So we also have a focus on the identify phase with working to identify strategies to help slow cost growth, such as the cost growth mitigation strategies that we all just discussed. And additionally of note is the upcoming project milestone of planning to publicly report the baseline benchmark findings this April. This project with this continuous cycle is a focus on healthcare affordability and expertly aligned with the primary charge of the PPC itself to systematically review issues related to the healthcare needs of residents of this state and the quality, accessibility, and affordability of healthcare. So I had also queried the commissioners to submit other topics or issues within the statutory charge of the Commission that they would like considered as an added priority and focus in 2023 to send in their ideas. I am happy to share that I've received input to improve healthcare accessibility thus far. Chair Khan and I would like to suggest for your discussion today that we consider accessibility and affordability as the two main pillars for the Commission's work over the year ahead. With this in mind, please understand we can always review a range of strategies to improve provider accessibility in 2023 to help bring forward educated and thoughtful recommendations to the governor and the legislature on both proposed pillars. So I've outlined the submission in the goal related to increasing healthcare accessibility here, with the objective in being to increase the percentage of medical school residents and nurses who remain in Nevada following their residency. An activity that might lead toward completion of that objective and in alignment with the goal is to survey medical and nursing residents statewide to determine what motivates them to either stay or leave Nevada after completion. So I've also outlined the Commission's annual statutory requirements as an added comprehensive goal suggested for inclusion in 2023. I would like to open this topic for a roundtable discussion on the Commissioner's thoughts, comments, or additions, and would like to begin with the Commissioner who proposed the added priority of healthcare accessibility, Commissioner Roe Dugan. So Commissioner, please go ahead.
Thank you so much, Melinda. Yes, so I did propose this idea for next year, as we have been talking about the shortage of nurses and the shortage of physicians in Nevada. It occurred to me that instead of us trying to figure out why the doctors are not staying after the residency and why the nurses are leaving, we asked them directly in a statewide survey. And I would like to ask the commissioners for their support in this idea. And maybe we can come up with strategies after we get the results of the survey on how we can meet their needs and maybe influence their decisions to stay in Nevada.
Thank you, Commissioner.
That's it.
Any comments from commissioners?
Yes, I noticed Commissioner McAllister, please go ahead.
Yeah, I second the proposal. I think it's a great idea. I especially want to know about medical students and nursing students and residents if they're leaving because of our state schools. So I hope the survey would include a large section on how they feel about raising families in our state. My big concern would be that we put the survey out there and people don't actually respond, right? So recently Medicaid did their quadrennial review of physicians to see the actual cost of delivering care, and out of 19,000 doctors, I think 12 completed the survey. So putting a survey out there and getting the information you want is not always the same thing. So if we could tie it to, I don't know, a graduation requirement or something that they actually have to provide the data.
Excellent. Thanks, Commissioner.
Thank you. Anybody else has any comments on this?
Yes, Commissioner Ralston.
Hi, thank you. I just want to echo the same comments of Commissioner McAllister, and really, I think it's a great recommendation. I just would like to make sure that you do foster as much participation as you can. And I would say that if you are going to explore this, that the commission consider some sort of actionable item that empowers you, Melinda, in your capacity as executive director, to use the resources available to you. Particularly, my mind comes to your budget, albeit quite small. I would like to make sure you have the tools needed to be successful. And if that is some sort of actionable item to empower you to use outside contract and some of the PPC budget money to get a third party to help you with this survey, I just want to make sure that we put that support behind you as well, so you are set up for success.
Thank you, Commissioner Austin. My quick comment on this is we need someone to help develop the survey questions first to begin with. And number two, if we are surveying the trainees, like medical students coming out or nursing students coming out or physicians assistants coming out, physical therapists, et cetera, in my opinion, this could be easily done before the year of their graduation from the medical school. The medical school, for example, nursing school, can require them to complete the survey before they graduate. It's a simple ask. At that level, it doesn't cost money, but it may cost some money to develop a proper survey that is comprehensive to get us the answers we are hoping for. Any other comments? If not,
I do see Commissioner DeSerbo.
Thanks. Yeah, just not a fully formed thought, but just wondering, if there's an easy ask to add on to this. I think this is great. Objective one, obviously, how do we keep our graduating physicians here? And if we're not keeping them here, why are they leaving? Something that comes up a lot when you interact with physicians here is why aren't they coming here? And one of the barriers is license portability and the lead time and runway needed to get licensed. It seems anecdotally in this state, we are an outlier, a couple standard deviations beyond what a normal amount of time for, say, a physician licensed in California wants to move to Nevada, set up a practice. Takes an inordinate amount of time, and I don't have hard and fast data, but I'm wondering if we have an easy ask from the state licensing agencies to see what is that average time for physicians moving into state and licensed, and maybe that pairs nicely with objective one. Keep them here, but then also try to draw them here, and maybe one impediment to that is the licensure.
thank you. Any other thoughts before we move to the next item?
Yes, Chair. I see Commissioner Bond.
Thank you. Yeah, I have a couple of thoughts. Thanks. I think it's great. I think it's a great idea to do this survey. Thank you, Commissioner Rodriguez. I think I was going to suggest, what about the idea of using the schools of public health and paying them to find a graduate student that made this one of their core assignments for the graduate degree. We have a graduate student right now getting her MPH, and she has to do this kind of thing to graduate. It might be a good way to find some money to do that, and then some continuity of somebody that could run it. Maybe we could get some professional support to help her, but I think it'd be a way to get our public health system a little involved in this, which would be great. And then secondly, I really appreciate what the last commissioner just said. I think that I would say, instead of looking at the average length of time it takes to get licensed as a physician, it would be really helpful to see what are the reasons a physician is not licensed quickly, because my understanding is, from a distance, there's a bunch of different barriers that can trigger an extended application. And I think that if we don't tackle those barriers specifically, the average will look like it's not an issue, but there really are serious issues. So I'd like a little specificity around that, but I love the idea about digging in on it. So thank you.
So these are important questions. I can just put in my 2 cents worth, having served on the medical licensing board for 8 years in the past. The perception is always there that there's a delay. The challenge is, on multiple occasions, that I know this firsthand, the documentation of graduation from medical school, especially if it was overseas, and or the residency programs and the reference letters, the medical licensing board wants those pieces of papers to come from that entity directly to the medical board. Reason being, on multiple occasions, if the applicant was requested to submit, forged documents were submitted. And we have had cases where a person never graduated from the medical school was to be licensed because there was a degree, if I remember correctly, from Vietnam that turned out was forged and was not original. And it was only identified much, much later. So that is our biggest challenge, because those things take a while. And until that original document of reference letters and graduation and residency programs, especially if they are overseas, it's a huge challenge and delay. Even in the United States, the priority of the resident chairperson and the medical schools is not to reply to the medical licensing board's request to submit a reference letter or a copy of the degree. And that also delays the situation. These things go by regular mail. The courier service costs money. The applicant, some of them, I was involved in some applicants calling me my license. I would tell them, you go to your chairman, you go to your medical school dean or whoever, and push them to send the paperwork ASAP. They've been sitting on it for a month or 6 weeks or 2 months. So that is a significant challenge.
Thanks, Chair. I do want to recognize Commissioner Van Houweling has his hand raised.
Oh, and thank you, Chair Khan. Definitely agree with your comments. And we've seen that in regards to just credentialing at the hospital post license. So it continues on and through some of the insurance panels. I do, Commissioner DeSerbo and Commissioner Bond had made some great comments in regards to the survey. And I did want to share with the PPC some of the things that we're working on that we can maybe hopefully expand out to UNR, but partnering with UNLV, Dr. Kate Martin, but I think many of you know our administrator, Shawnatello, is working with the UNLV Healthcare Administration Program, which I'm partial to. And we welcome those students in, but one of their projects is going to be doing this exact same type of survey. So we're kind of working on that, Commissioner Bond, to your point of tapping into our resources as part of their projects for graduations. But we've identified that with Dr. Kate Martin, who's the DIO for UNLV. But maybe once that work's done, we would be glad to share that via Shawnatello and Dr. Martin, and then hopefully partner with UNR to do the same thing too. If we kind of do the work, perhaps they can tailor it to their own medical students and find out some of those causes and some of those thoughts of the students. But just some thoughts, Chair Khan, and we'll bring that work back when it's done.
Thank you very much, Commissioner Van Houweling. Anybody else has any thoughts?
I did see Commissioner Bond. Did you have a question or thought?
I did talk so much. I'm sorry. I was just gonna say, I think that based on everything you just said, Chair Khan, maybe it would be great to, again, just see the reasons for the outliers, because I think that if it takes somebody 6 weeks to get something in the mail, is the problem that we're trying to go back 25 years in records when the physician's been a physician in good standing in another state for 15 years. We really need to start 40 years back in their life. I think that those would be good things to talk about, but I think we can catch that if we look at what are the reasons it doesn't happen rather than the average length of licensing time. And to Commissioner Van Houweling, I think it'd be great for us to get both the universities involved. I don't want to take away from what Commissioner Roe-Dugan was trying to do, though. Maybe there's a way to collaborate on what's already going on and get the rest in there and not have to wait until one group's done before another group starts. I don't know. We should try to figure out a way to move through this.
Yep. Thank you, Commissioner Bond. Anybody else online, Melinda?
Yes, I do want to recognize Commissioner Winkler.
Thank you. And I want to first say I really love Commissioner Roe-Dugan's idea. And I love the ideas that the other commissioners have talked about and how to implement that and strengthen that. I wanted to talk about some other objectives of improving healthcare accessibility. It definitely seems like we've coalesced around looking at licensure. I also wanted to bring up that a great deal of the board is focusing on affordability and how that affects access. But I want to do more work into finding out what else affects accessibility, such as transportation or, cultural biases or things that people that they have to get over it and to be able to see a healthcare provider. I'd like to know more about that, and I think that works a lot with our commitment to health equity. Thank you.
Thank you. Anybody else before we move on? Melinda?
Not seeing any further hands raised, Chair.
Okay, good enough. Our next item on the agenda is public comment. Do we have any?
Quickly, Chair, I apologize. There's one more slide. I wanted to talk to the commissioners about the meeting cadence in 2023, if that's all right.
Please.
Excellent. Thank you. So I've asked the commissioners in a few email weekly updates. It was brought up a meeting asking for potential in-person meetings. And so to address that, I just wanted to put up some different options that we might think about for 2023. I have 3 options here. I did not put meet 100% in person just because we don't necessarily have the budget for all of that. But I did put to either meet 100% virtually as we are now, or to meet two times a year in person, or 4 times a year in person. So just wanted to pose that for discussion of the commissioners. And then also, if 9 a.m. on the third Wednesday of the month still works for everyone, I can also send out that calendar hold. So
So
just
from
wanted to, go ahead.
I'll use my privilege as chair. For me, Wednesday has become a little challenge for some time, but I've worked my schedule around. For me personally, at least Thursday morning works better, but we'll see what everybody else thinks about that. So comments?
Commissioner McAllister?
Yeah, Thursday morning would be okay for my schedule. And I favor virtual meetings. I think they're more productive.
How many commissioners in favor of virtual meetings? Let's narrow it down that way.
Would you like me to do a roll call on that, Chair?
Yeah, I mean, just raise of hands is fine, or maybe we can say anybody opposed to all virtual meetings. That'll simplify it.
Okay, okay. So if there's anybody opposed to 100% virtual meetings, please raise your hand. Okay, and I see Commissioner Van Houweling has his hand raised as the one.
I just like in person. I think it's just better for the collaboration of the team and working together. But I'm fine with Thursday's Chair Con. Hopefully Holly doesn't kill me, but I'll make that decision and I'll deal with it. As you all know, she's the boss. But I just I feel it's good to collaboration and just synergies and for us to get at least. I'd like to at least go 2 at least, but prefer option 3. But just my choice. But I'm a flexible guy.
All right, thank you. Anybody else has any comments on this?
Yes, Vice Chair Rubelin.
Yeah, I just wanted to say that I would support meeting at least once, maybe twice a year in person. It's just difficult for those of us who are up north. You know, I know most of the commission is in Las Vegas, so travel is a concern, but we could probably make it work at least once a year. I agree, it would be nice to meet in person. It just can't happen once a month. That's just not possible.
Yeah. Thank you. And then Commissioner Bond.
I agree. I think it'd be great to meet once. I think it's hard to meet all the time. So, but I totally agree that collaboration is improved when you see each other and talk to each other face to face. I think it makes a big difference. And there's a lot of commissioners I've never met. So if we could do like one meeting, it'd be great. I just can't do Thursdays because that's when the coalition work is. So, Dr. Khan, let me see if I can move the coalition work before I give you a hard no here. But I currently do have a conflict on that.
Okay, great. Appreciate it.
Okay.
I have no problem with once a year in-person meeting either, so just for the record.
Thank you, Chair. I do want to recognize also Commissioner Ralston.
Yeah, I just want to say I don't have a conflict with Thursday. I'm okay with that. I also am okay with 100% virtual. But I do agree that it is nice to see everyone in person from time to time. So it would be nice to have maybe one person meeting with all of us. And then for anyone in Southern Nevada, I would throw it out there to all the commission members that I would be open to meeting with the Southern commissioners in one virtual space for a meeting. And maybe it'll be kind of a group. I don't know, whoever has the largest office, or, you know, maybe hosting at a virtual space that at least a handful of us could meet in person and then join together virtually. So maybe that's a nice compromise for some too.
Okay, thank you. Anybody else you're finding, Melinda?
I am not seeing anyone. I still see Vice Chair and Commissioner Bond's hands raised, but I think that okay, good to go.
Okay, so we're on to public comment now. Do you have anybody identified for public comment, Melinda?
Sure. And quickly, just before I go to that, I did want to note that Commissioner Tyler Gardner in the chat noted that Fridays worked better for her, but just wanted to throw that out there.
Okay, thank you.
Thank you.
Okay, anybody for public comment?
Public comment, again, if you're on the Zoom platform, please use the raise hand feature to provide public comment. Otherwise, if you are calling in, please press *9. And I do.
Thank you. So I received two private messages during this meeting, and I just think that they should probably be out there because it seems like there might be some misunderstanding. The first one was a question about whether or not the presentation I provided stated that Rhode Island was the only state to oversee the large group market. That's not true. I have no idea. We were just researching Rhode Island to give people an understanding. So that would be a bigger question that we didn't address. And the second one says, I'd like to dig into a bit on why the DOI does not seem to be interested in the oversight of the large group market. I honestly don't understand since they often complain about not overseeing ERISA. I just want to make sure to clear the decks here. We're not complaining about overseeing or not overseeing ERISA. It's just a fact. I mean, I'm sorry if it came across that we were complaining, but it's just a fact. And it should be taken just as a fact. And as far as overseeing the large group market, my presentation was really to tell you what the issues were and that it couldn't be easily integrated into the current oversight in the small and individual markets. That's really all it is. As far as whether or not we're interested or disinterested, it just takes people, and it's a policy decision that gets made by the legislature, not us. So I don't really have any, and I don't think anybody in the agency has any real feelings about it. It just would take bodies and a bit of focus, if that helps.
Thank you very much. Thank you. We're down to our last item of adjournment. If nothing else, we'll stand adjourned.
Thank you.
Thank you. Bye,
Thank
everyone.
Thank you, everybody. Good meeting.